In this video, we will be discussing medications that are available for the treatment of COVID-19. Treatments for this coronavirus continue to evolve. The one drug that has previously been proven to be efficacious in other coronaviruses and now in SARS-CoV-2 is the ribonucleotide analog remdesivir. This adenosine analog inserts into the growing RNA chain and causes premature termination, thereby preventing RNA replication. This agent is given intravenously, 200 milligrams on day 1 and then 100 milligrams for an additional 4 or 9 days. The NIH ACT-1 trial consisted of 1,062 patients with severe disease. Patients were randomized to remdesivir or saline. The final analysis reported in the New England Journal reveals the median hospital stay was 10 days for the remdesivir patients versus 15 days for the controls. Mortality was decreased from 11.6% to 6.7%. The benefits of treatment were higher for those with less severe disease and those who received remdesivir within 10 days of the onset of illness. Mathematic modeling of the data from the trial by Finzi et al. Reveals that remdesivir stops the progression of disease but cannot reverse the damage that has already been done. Therefore, remdesivir should be given as early as possible to halt disease progression. We administer the medication in the first few hours of hospitalization to maximize the benefit of this drug. To reverse the inflammatory damage caused by severe SARS-CoV-2 infection, anti-inflammatory medications can be of benefit. Remember, SARS-CoV-2 stimulates foreign pathogen pattern recognition receptors, TLR2 and TLR4, as well as TLR7 and 8. And binding to these receptors results in the production of multiple cytokines, including TNF, IL-1, and IL-6. Corticosteroids are a well-known anti-inflammatory agent that can dampen the inflammatory response. The United Kingdom National Health Service, NHS, conducted a randomized clinical trial, RCT, called RESCUE, that was published in the New England Journal of Medicine. Administration of the corticosteroid dexamethasone at 6 milligrams per day demonstrated a reduction in mortality among patients requiring ventilation from 41% death rate to 29%. Among those receiving oxygen but not requiring a ventilator, mortality was reduced from 26 to 23%. No benefit was observed for patients not requiring oxygen. Here is the plot of mortality over time in patients requiring ventilator support. The upper black curve is the placebo group, and the dexamethasone is the lower red curve, demonstrating a significant reduction in mortality. A second group of anti-inflammatory agents are the IL-6 inhibitors, tocilizumab and sarilumab. These monoclonal antibodies block IL-6 activity, and in combination with corticosteroids have been shown to enhance survival in patients with severe COVID-19 by 1.6-fold, as shown on this graph, plotting days versus percentage survival. Notice that at 90 days, the number surviving is higher in the treatment group, 255, versus the control group, where only 225 survived. The final anti-inflammatory therapy that has been used to treat COVID-19 is baricitinib. This agent blocks the JAK1/2 pathway required to activate the production and release of IL-1, IL-6, IL-10, TNF, interferon gamma, and granulocyte macrophage colony stimulating factor, GM-CSF. In the NIH ACT-2 trial, a combination of baricitinib and remdesivir was compared to remdesivir alone. 1,033 patients were randomized. 518 received remdesivir and baricitinib, the combination group, and 515 received remdesivir alone. Time to recovery was shorter in the combination group, particularly in those who required high-flow oxygen or non-ventilator respiratory support, 10 days for the combination versus 18 days for remdesivir. Mortality was also significantly lower for this group, 7.5% versus 12.8%. Here's the graph plotting percent recovering on the vertical axis over time for high-flow oxygen non-mechanical ventilation support group. Note the higher recovery rate for those receiving baricitinib and remdesivir, blue curve, versus remdesivir alone, red curve. A recent meta-analysis of 4 major clinical trials has demonstrated that patients who are experiencing worsening respiratory function on remdesivir and dexamethasone benefit from adding baricitinib. As shown in these forest plots, relative risk of mortality at 28 days dropped to 0.7, and duration of hospitalization was shortened by 2 days with the addition of baricitinib. The IDSA does not recommend combining baricitinib with IL-6 inhibitors. One or the other is recommended if the patient is deteriorating despite remdesivir and dexamethasone. To summarize current treatments for hospitalized patients, remdesivir, dexamethasone, IL-6 inhibitors, and baricitinib all show modest benefits. However, none of these therapies can be interpreted as a home run. Supportive care, allowing time for patients' damaged organs to heal, remains the mainstay of therapy. More recently, an effective combination antiviral drug with the trade name Paxlovid has been FDA approved. This oral pill contains the antiviral agent nirmatrelvir that inhibits a SARS-CoV-2 protease, P3CL-Pro, and thereby blocks viral replication, and ritonavir is the second agent, an inhibitor of cytochrome P453A4 that slows nirmatrelvir metabolism and increasing its serum levels. Preliminary studies revealed that if given within 3 days of onset of symptoms, progression of COVID-19 to severe disease was reduced by 89%. A subsequent study in the New England Journal found early treatment of those 65 and older reduced hospitalizations by 75%, but had no benefit in those under 65. This graph demonstrates the impressive benefits of Paxlovid in those 65 and older. Note the marked reduction in the risk of being hospitalized in the treated group, the orange line, versus the untreated, blue line. As shown in this forest plot from a large study in Israel in the clinical infectious diseases, this drug also reduces the risk of hospitalizations in patients with many chronic medical conditions. A value to the left of the dashed line is equals to less than 1 and indicates benefit. A benefit is particularly high in patients with chronic neurological disorders and patients on immunosuppressive agents. The Infectious Disease Society of America, IDSA, recommends that Paxlovid should be given within 5 days of onset of symptoms to anyone aged 12 years or older who is at increased risk for progression to severe disease. The standard dose, 300 milligrams of nirmatrelvir, 100 milligrams of ritonavir, twice per day for 5 days. Drug interactions are a concern, particularly for patients with organ transplants taking drugs to prevent rejection. Another concern is that some patients, 3 to 5%, experience a rebound upon completing their treatment. Symptoms return, they begin shedding the virus again. Symptoms during the rebound tend to be mild and patients subsequently recover. Repeat treatment is not recommended. Recently, VV116, an orally absorbed remdesivir with potent activity against SARS-CoV-2, was compared to Paxlovid in a human trial. As shown in this graph from the New England Journal, the rates of recovery of VV116, the orange line, could be superimposed on the blue line for Paxlovid, indicating comparable effectiveness. This agent's toxicity profile is superior to Paxlovid. The oral version of remdesivir has not as yet been approved by the FDA, but is a promising alternative to Paxlovid. A third oral antiviral agent has also been released called molnupiravir. This ribonucleoside analog incorporates itself into the replicating viral RNA and blocks RNA synthesis by the virus. When molnupiravir was given within 3 days of onset of symptoms, for 5 days, hospitalizations were reduced from 9.7 to 6.8%, or a 30% reduction in hospitalizations. A similar reduction in deaths was seen. Given the modest benefit of molnupiravir, in most cases, Paxlovid is preferred for early treatment. In addition to antiviral agents, another important intervention is anticoagulation for all patients hospitalized with acute or critical COVID-19. Early studies from China revealed a higher mortality among those with elevated D-dimer values, as shown in this graph, but they did not comment on the incidence of venous thrombosis or clots. We now know that SARS-CoV-2 infects the endothelium or lining of blood vessels, a condition that stimulates coagulation and the production of D-dimers. For more details, please see the optional section for Advanced Management of COVID-19 for Health Professionals, videos on thrombotic complications of COVID-19. The American Society of Hematology, ASH, has been continuously monitoring studies on anticoagulation in COVID-19 and assessing these studies using the analytic tool GRADE, described in the next video. When it comes to the benefit of anticoagulation, the evidence continues to be of very low certainty. As of May 2022, the ASH panel recommends prophylactic heparin or Lovenox over intermediate or therapeutic doses for critically ill and acutely ill COVID-19 patients without proven thrombosis or blood clots. And all patients with COVID-19 admitted to UF Shands receive this treatment. Are there any other treatments of benefit? In my previous video on treatment, I suggested that convalescent plasma from patients who had recovered from COVID-19 might be of benefit. However, subsequent randomized clinical trials have failed to show benefit, and this treatment is no longer recommended. Although the combination of two monoclonal antibodies called Regeneron was shown to be a benefit for the alpha and delta variants of SARS-CoV-2, this agent has no impact on Omicron infection. Omicron's very different surface proteins are not recognized by this antibody preparation. In anecdotal case reports, hydroxychloroquine, chloroquine, and ivermectin were all thought to be of benefit. However, multiple randomized clinical trials for both prophylaxis or prevention and treatment have failed to show any benefit. Giving hydroxychloroquine, chloroquine, or ivermectin are equivalent to treating COVID-19 patients with a sugar pill. To summarize the pharmacologic treatments for COVID-19, we have no magic bullets. However, remdesivir, dexamethasone, tocilizumab, and baricitinib do show modest benefit in the treatment of hospitalized patients. Two oral antiviral treatments, when given within 5 days of onset of symptoms, reduce hospitalizations. Paxlovid by 81%, molnupiravir by 31%. An oral version of remdesivir, VV116, is comparable to Paxlovid in its effectiveness. All patients admitted with acute or critical COVID-19 should receive prophylactic doses of an anticoagulant, either sub-Q heparin or Lovenox. Convalescent plasma, as well as dual monoclonal antibody administration, are ineffective against Omicron variants. Other agents not shown to be of benefit include hydroxychloroquine, chloroquine, and ivermectin.